Bismillahirrahmanirrahim. Assalamu alaikum. Welcome you all to the grand round of neurology of this month. I want you guys to know that how excited I am to be a part of this and to communicate to you in these tough times. So the topic of today's talk is neurology in the time of COVID. So humanity has but three great enemies: fever, famine, and war. Of these, by far the greatest and by far the most terrible is fever. These were the words of the great Sir William Osler in 1896. And even after more than a century and a half, these words hold true. The newly emerged severe acute respiratory syndrome coronavirus 2 has stricken fear and panic among the public, healthcare workers, patients, politicians, and financial markets. Fear strikes the mind of the unprepared. So we must ask ourselves, why have we been caught by surprise? In the recent past, there have been many major epidemics. This includes Ebola, Zika, dengue, acute flaccid myelitis, chikungunya, and H1N1 influenza, to name a few. But what is different about SARS-CoV-2? The difference is that it struck home, and so very rapidly. It emerged in the region of Wuhan, China, in December 2019, and rapidly shifted its epicenter from China to Europe to the United States of America in a matter of 2 weeks. This is what makes it so very different from the rest of the pandemics that we have seen in our lives. So since we are going to discuss about how the coronavirus involves the brain and causes the neurological manifestation, I would like to discuss with you guys about how does it invade the neurological system. So the protective mechanisms described to explain the neuroinvasion are basically two. Number one, hematogenous, and number two, retrograde axonal support transport. However, there are few more mechanisms that have been postulated recently. One of them is direct viral invasion of the brain, leading to clinical encephalitis, as has been seen by a case report from Beijing, in which SARS-CoV-2 was isolated from the CSF of the patient by genome sequencing. Another indirect mechanism of brain injury is hypoxia. Since we all know that COVID-19 is widely known to involve respiratory system. So with the development of pneumonia and ARDS, it can cause hypoxia. And this hypoxia can lead, if untreated or unable to be controlled, can lead to hypoxic brain injury. Another mechanism, which is a well-known immune reaction to any viral infection, is a cytokine storm. In this particular case, it is further supported by the observation that interleukin-6 has been found to be in enormous amounts in the body after a coronavirus 2 infection. So this will lead to inflammation and injury of the central nervous system tissue. Okay. This particular mechanism that you are currently seeing on your screens is what is currently at the hot seat of academic discussion. The role of angiotensin converting enzyme 2, or shortly ACE2. ACE2 is a protein factor that is present on a lot of surfaces: heart, brain, blood vessels, skeletal muscles, to name a few. The expression of ACE2 in the nervous system and skeletal muscles can indeed explain some of the neurological features reported so far. The viral attachment to the ACE2 at the level of blood-brain barrier may jeopardize the protective mechanisms surrounding the encephalon, giving way to viral encephalitis. In a similar way, spinal cord membranes expressing ACE2 can culminate into myelitis-like features following SARS-CoV-2 infection. The viral particles binding to ACE2 on the cerebral blood vessels may actually raise the luminal pressure of these vessels, leading to the intracerebral hemorrhage that we are seeing associated with this virus. Okay, so this is one of those symptoms which are very hyped about and talked about, and for good reason. So coronaviruses in general have a history of invading the brain through the olfactory pathway. So I thought it would be a good idea to share a little bit of anatomy with you guys. So the anatomy, unlike rest of the neurological pathways in the brain, olfactory path is fairly straightforward and short. So if you look at the left side of your screens, you can see the olfactory epithelium. This is where the pathway begins. These are bipolar cells that cross the cribriform plate and synapse in the olfactory bulb. In the olfactory bulb, the pathway divides into two. It's a pair, and these two branches move back towards the olfactory nucleus present in the piriform cortex. This nerve root has been used by some coronaviruses in rodent models exposed to nasal inoculation. Okay, so now we will discuss some neurological manifestation, some general manifestation followed by neurological manifestations. So this is a common knowledge now, and due to the such a great public awareness, everybody knows that this viral infection starts with mild symptoms such as fever, headache, cough, dyspnea, myalgia, and anosmia. Some unfortunate ones develop acute respiratory distress syndrome about a week into the illness, which can result in death. Rhabdomyolysis can be a late complication of the infection, and terminally, patients go into coma, which is thought to be due to hypoxia or multi-organ failure. Neurological complications of COVID-19 can be discussed under three headings. Number one, neurological features of viral infection that happen directly because of the virus. Number two, post-infective neurological complications that we see with other viruses as well. And infection in patients with neurological comorbidity, that is, those patients who have neurological diseases for a good while and are on some sort of treatment. Another issue that deserves special mention here is the precautions that need to be taken in neurologically ill patients who require immunosuppressive agents such as multiple sclerosis, myasthenia gravis, and autoimmune encephalitis, to name a few. Okay, coming to the neurological manifestations. We can further subdivide it into central nervous system features and peripheral nervous system features. CNS features include headache, dizziness, ataxia, altered sensorium, encephalitis, stroke, and seizures. And if you look at the peripheral nervous system, we would most often see skeletal muscle injury because of the rhabdomyolysis and peripheral nerve involvement in the form of hypoosmia and hypogeusia. The same mechanism, probably secondary to the same mechanism we described earlier because of the olfactory lobe involvement. Okay, so now we will discuss a few of them in detail. So the first symptom, and a really common symptom that we see with COVID-19 is headache. Now, headache is reported in 6 to 13% of the individuals who report neurological symptoms of COVID-19. Headache can be a symptom of viral syndrome. As we all know, we get flu, we get headache. But is it really that simple? Or could the headache be symbolic of viral meningitis, or for that matter, encephalitis? Concerns have already been raised in recent correspondence if this particular symptom is really a manifestation of just any viral syndrome, or could this portray something more serious and potentially fatal? Japanese colleagues shared their case with the world in International Journal of Infectious Disease, in which they presented a case of a young man who never traveled outside. And on day one, he just developed fatigue and fever. He saw doctors twice, and he was given antiviral and antipyretics. And the next thing we knew that his family found him lying on the floor unconscious in his own pool of vomit. He was immediately transported to the hospital. All the workup was done, and he showed SARS-CoV-2 RNA in CSF, but interestingly, not in the nasopharyngeal swab. Rest of the virus battery was done, which was negative. An MRI was done, and I want you guys to have a look at it. So if you see, this is an MRI brain, this is a DWI, and you see a hyperintense signal on the right mesial temporal lobe, and the presence of pansinusitis. So this was postulated that this is directly caused by the SARS-CoV-2 RNA inoculation in the brain and causing the meningitis/encephalitis in this particular patient. The second case is of a female airline worker in her late 50s who had 3 days history of cough, fever, and altered mental status. Her nasal swab was positive for SARS-CoV-2, unlike our previous patient, but unfortunately, the tab was traumatic, and they could not do SARS-CoV-2 in her CSF. But here is how her imaging looked like. So if you see, this panel A is a CT brain plane, and you see this area of hypoattenuation in the bilateral medial thalami. Now, if you see this in any patient with such a rapid history, you would think of diseases like acute stroke, could be venous infarct, and that's why they did a CTV in the panel B, and you can see the patency of the cerebral venous vasculature, including the internal cerebral veins, which was normal. And this is not a great picture, but you can still figure out the posterior circulation anatomy, basilar, and the posterior circulation patency, and the proximal posterior cerebral arteries and basilars were normal. Then MRI of the same patient, and if you see a whole array of lesions. So let's start counting. In the bilateral medial temporal sclerosis, periventricular area, bilateral thalami. So, and it shows a rim enhancement on the post-contrast images. On the susceptibility weighted images, you can see hypointensity, which is indicative of hemorrhage. Now, all the residents that are listening right now should be thankful, because I cannot point them out and call them out to explain the MRI for me. So yeah, good times for you guys. So this brings back to our question of, is headache a viral symptom? So the answer is yes, it is a viral symptom, but this does not change the fact that it can be a part of something very grave and something that needs attention right now or in time, or the result can be disastrous. So pay attention and analyze even a simple symptom such as headache in a known COVID-19 case, especially if the headache is out of proportion to a rise in temperature and is associated with certain other features such as vomiting and altered sensorium. Okay. The second very important aspect of neurological manifestation of COVID-19 is the presence of, or is the occurrence of cerebrovascular events, aka stroke. So the initial retrospective case series that we received from China, they reported 5 out of 76 cases that showed acute stroke. 4 of those cases were ischemic stroke, while 1 had a cerebral hemorrhage. Another recent paper from the same center, but with a much larger patient number, 221, elaborated that 13 out of 221 cases had some sort of new onset stroke. Well, the percentage is pretty much similar, but just because the denominator increased, so did the numerator. The majority of them presented with acute ischemic stroke, while only 1 patient had a hemorrhagic stroke, and 1 patient had a cerebral venous sinus thrombosis. Therefore, it is evident that thrombotic manifestations were way more frequent than the hemorrhage. Okay, so what's the deal behind it? Why we are seeing more strokes in COVID-19? So patients with stroke were more likely to have enhanced inflammatory response as reflected in their C-reactive proteins and D-dimers. So C-reactive proteins and D-dimers were found to be much high in stroke patients as compared to the other patients. It is within the realm of possibility that the viral infection may have given way to an inflammatory storm that ultimately culminated in accelerated thrombosis. Now, this culminated thrombosis, this term seems more meaningful if we see in the context of another finding in this particular study that I'm mentioning. In this study, the stroke was not present, not just present in the older population, but was also present in people who were younger, but they had pre-existing vascular risk factors like hypertension. So any viral infection in a stroke patient not only delays the recovery, but also may actually worsen the neurological deficit, the latter being sometimes attributed to hemorrhagic transformation. So the mortality rate was obviously higher in COVID-19 stroke patients as compared to those COVID-19 patients who did not have a stroke. So the relationship between COVID-19 and stroke is two-way, which a neurologist has to bear in mind. The application of antiplatelets and anticoagulants is tricky because the virus is known to cause prominent respiratory involvement. And according to some authors, the involvement of the nervous system may be partly attributed to it. So the management of the stroke has several challenges, not just clinical, but also social. All over the world, the stroke centers are reporting that they are seeing lesser number of patients with stroke symptoms presenting to ER, especially those with mild strokes or TIAs. Number two, there is reduced staff due to illness or redeployment and potential admissions of COVID-19 positive stroke patients to general medical wards rather than stroke units. Staffing of stroke unit by non-stroke experts and limited access to critical care monitored bed. So you see these challenges, and when, as a stroke neurologist, you see how badly they could reflect. Because let's have a look at the number one. We are seeing lesser number of patients. Why do you think that is? Well, we don't have any data to confirm this, but the plausible theory is that people have a fear of contacting coronavirus from the hospital. Hospitals are a place which they rightfully consider it to be a reservoir of infection. So people who have mild strokes or TIAs are not coming to the hospital. They would be like, I might as well live with this symptom rather than going to hospital, catch the disease, and be gone for good. So those mild strokes or TIAs that you can catch in time and prevent them from having another bigger stroke in the future are not coming to ER. And that is a huge, huge problem for us coming in the future. Secondly, obviously there is the ER is choked, the critical care is choked, and the ER team or the critical care team can only do so much. So we have to redeploy the staff. Now imagine me going over to the critical care as, I don't know what, like a medical officer maybe. I would have to think twice before intubating somebody or conducting the whole advanced cardiac life support. And hell no, I wouldn't even touch a ventilator. So you can imagine what problems can this cause, this redeployment. And then of course, we as the doctors, as human beings, can also get sick and with the same disease or with any other disease. And obviously there will be reduced staff. And vice versa, if the stroke unit is staffed by the people who do not have any or long-term training in the stroke and limited access to critical care beds. So these are the challenges that we are seeing already in our hospital in the stroke management. So the key messages here put forwarded by the respected stroke bodies all over the world are that stroke is a medical emergency irrespective of the pandemic. And existing evidence-based stroke guidelines should continue to be followed. I mean, just because it is war in a different zone does not mean the stroke or other diseases like MI or a ruptured placenta are any less of problems. Evidence-based stroke care is highly effective at reducing mortality, length of stay, improving functional outcome, and preventing recurrence. So sticking to what you know and what you have been practicing according to the evidence base would actually help the healthcare system in reducing the workload. There is the need to continue to raise awareness with the public that stroke is a medical emergency and they need to seek medical attention without delay despite COVID concerns. This is not something that you want to sit over at your homes. Hyperacute stroke response teams remain available to treat acute stroke. Changes in workflow processes are required within a protected court stroke model, and this is what our team currently in the neurology is working over it, to put forward a protected court stroke for those patients who are hyperacute strokes, where they are suspected to have COVID-19 too. Stroke patients should continue to be cared for in a specialized acute stroke units where possible. Education and basic skill training may be required for non-stroke experts caring for stroke patients to ensure patient safety and optimizing recovery. Where access to critical care beds become limited, this care can be taken to a ward or a stroke rehabilitation bed with appropriate supports. And the need of the hour in this current pandemic is that of telestroke or telecommunication. You can thrombolize a patient on a telestroke. So really, if this system comes into place, we will be very much able to help our acute stroke patients even without them coming to a tertiary care facility. Barriers to access and utilization should be considered and workaround solutions implemented. Of course, it is easier said than done. Okay, so enough time for stroke. I was a little partial to the stroke for obvious reasons. Okay, so the third symptom that I would like to come to is the impaired consciousness. Impaired consciousness has so far been reported in 7.5% of the hospitalized patients. So you have to see what is the denominator here. So hospitalized patients. That already means that we are talking about the COVID-19, which is moderate to severe. And severely affected patients are obviously more likely to present with impaired consciousness. Now, the problem is that there can be multiple underlying reasons for a patient with COVID-19 to present with altered sensorium, which can range from viral encephalitis, metabolic disturbances, infectious, toxic encephalopathy, seizures with post-ictal confusion, and stroke. Either a large stroke or a well-placed, strategically placed stroke. So, what I want you guys to shift your focus on as medicine team or ER team or even as a neurology team, that how important it is to recognize this non-specific feature as a possible COVID symptom in time. So altered sensorium indeed has drawn the attention of the neurologist mostly because it delays the diagnostic procedures as the virus is widely known to be a respiratory pathogen. So what I'm trying to communicate here is that the knee-jerk reflex is that virus would present with shortness of breath, fever, right? And if a patient comes with nothing but altered sensorium, COVID-19 would not be our first guess. However, an altered level of consciousness may precede typical respiratory symptoms by days. So that is, the patient will not present with respiratory symptoms of days after presenting with altered level of consciousness due to COVID-19. Given the transmission dynamics of the infection, this information is extremely important as healthcare providers at the ER may get inadvertent exposure while handling patients with altered sensorium. Okay, so the fourth manifestation of this disease that I'll be discussing is epilepsy. How much time do we have? 30 minutes? Okay, good, very good. So epilepsy. Epilepsy and COVID-19 has multifaceted association. Initially, it was thought that epilepsy per se is not really a COVID-19 disease, but as the data began to pile up, we saw that, and I would discuss a couple case reports with you, that seizures are seen as the presenting features of COVID-19. So, but the association is much more than that. Number one, we can have a viral meningitis or encephalitis like we just discussed with COVID-19. And these diseases per se can cause a seizure, which we call a symptomatic seizure. Secondly, this particular infection is known to cause fatal pneumonia that gives way to severe hypoxia. Severe hypoxia can lead to hypoxemic brain injury and ultimately seizures. Metabolic disturbances and septic encephalopathy are some of the other concerns that need to be taken care of while attending a patient with seizure. The later causes belong to the so-called group of acute symptomatic seizure. Thirdly, non-epileptic patients with COVID-19 may experience increased frequency and severity of seizure because of the known fact that the threshold of seizure is lowered in association with fever. Also, seizure supposedly would complicate the clinical situation by the agency of skeletal muscle injury. So skeletal muscle injury will be twofold. Number one, because of the COVID-19 per se, because of the ACE2 receptor presentation on the skeletal muscle, as well as the seizure that can cause skeletal muscle injury. The fact that neurological complications are more frequent in severely ill patients and also cardiovascular risk factors are predictors of severity, the drug interaction potential of several anti-epileptic drugs would deserve attention in such clinical situations. Thereof, from a neurologist perspective, seizure in a COVID-19 patient will have some important implications, both from the diagnostic as well as therapeutic perspective. So, as any physician, general physician, we have some questions. So is seizure a symptom of COVID? We partly answered that already, but I would like to share a couple of case reports in a few seconds. Then the second question, are people with epilepsy at higher risk of developing COVID-19? What factors may increase the risk from COVID-19 for a person with epilepsy? And can seizure increase if a person gets COVID-19? So let's have a look at them one by one. So yeah, the straightforward answer to this question is yes. The first case report of a patient presenting with convulsive seizures was presented in March 2020. It was a 30-year-old previously healthy female admitted with generalized tonic-clonic seizures. The patient complained of dry cough for 5 days before admission. She had seizures approximately every 8 hours. Her brain MRI was normal, and a CT chest were characteristic of COVID-19. The respiratory symptoms were positive. A specimen was positive for COVID-19 using real-time PCR assay. The symptoms of the patient improved with anticonvulsive and antiviral medication. So this was the first case which showed us that COVID-19 can present with generalized tonic-clonic seizures. Then another case report from Italy suggested that COVID-19 can lead to breakthrough seizures. So they described a case in which a patient had previous history of seizures and they developed a focal status epilepticus as a presenting symptom. She had a previous history of herpes encephalitis, which was well controlled for the past 2 years. However, after contacting COVID-19, she developed focal myoclonus suddenly and required hospitalization and IV anti-epileptics. Okay, are people with epilepsy at higher risk of developing COVID-19? So the answer to this is also fairly straightforward, that it does not increase the risk of COVID-19. It does not increase the severity of COVID-19. So all those epileptics out there, if we have people from non-medical side or laymen who have seizures, you do not need to be worried about your chances of getting COVID-19. They are equal to any other person who does not have seizures. Can seizure increase if a person gets COVID-19? So well, this is a general. The answer to this is yes. So when a person with epilepsy gets sick with any other illness, especially with a fever, they may see a change or increase in the seizures. They may have breakthrough seizures or their seizure frequency suddenly increased enormously. So the illness is a physical and emotional stressor to the body that could make seizures more likely. The same happens if someone is sick with COVID-19. So this infection is nothing different than other illnesses which involve fever. Okay, what factors may increase the risk of COVID-19 for a person with epilepsy? Some people with epilepsy, regardless of seizure control, have other health conditions that put them at higher risk from COVID-19. For example, they may be taking drugs that are affecting their immune system, like ACTH, steroids. So it is important to note that most seizure medications do not affect the immune system. So that our usual anti-epileptics that we use in our clinics do not mess up with our immune system. So those who are not on any sort of steroids or ACTH or immune therapies, they are safe. Some people may have other neurological or developmental issues that affect their immunity, like developmental disorders or leukodystrophies. Those are the children, especially, who have their immune system not built up as a normal individuals, and they will be more susceptible to have any viral illness and, of course, COVID-19. People with epilepsy may have other medical problems that could place them at higher risk. For example, they may have swallowing problems or frequently inhale food or liquids into their lung, causing aspiration pneumonia, and that may make them susceptible for acquiring COVID-19 pneumonia. Patients with diabetes or underlying heart or lung problems also appear to be at higher risk. So the message here is that apart from a very small subset of epileptics who are either taking immunosuppressive medication or whose epilepsy is a part of a developmental or neurological syndrome that affects their immunity, rest of the seizure population is generally do not have any higher chances of acquiring COVID-19. Okay. So another comment, so I think we are shifting from CNS to the peripheral nervous system, and I would like to discuss here the skeletal muscle injury. So symptoms of skeletal muscle damage, often associated with liver and kidney involvement, have already been noted. The reported incidence is 10.7%, and like other neurological features, it is more commonly seen in severe COVID patients compared to mild to moderate COVID patients. It can be speculated that patients with pre-existing renal or hepatic impairment will be highly vulnerable to develop features of multi-organ failure in the backdrop of skeletal muscle injury. Muscle enzymes, including creatine kinase and lactate dehydrogenase, are seen to be highly elevated in the symptomatic patients, an observation that confirms muscle membrane damage. The exact mechanism of muscle damage, however, has not been established. Possibilities include the presence of ACE2 receptor tropism and immune-mediated muscle fiber damage. Okay. So like I said, there is a subset of complications of symptoms that occur because of the virus infection. And then there are some post-infective neurological complications. And with more number of patients recovering from the SARS-CoV-2 infection, it is imperative that post-infective complications would draw their attention with time. So I would like to discuss two. Number one is the Ganbara syndrome, also known as GB syndrome. The first case report was obviously from China, that patient developed symptoms of COVID 7 days after hospitalization for GBS. So here is the scenario. The patient was admitted with GBS, and after 7 days of their admission, they developed the symptoms for COVID. So the causality in this case is not determined. However, in the retrospective analysis, it supports that she might have been harboring the infection since the beginning, because at her admission, her blood count showed lymphocytopenia and thrombocytopenia. The authors duly speculate that the initial symptom may have been too mild to be detected in this patient, as fever is present in less than half of the cases during the initial phase. Then further studies were seen of the cases of GBS in COVID patient. This is a case of 5 cases that were reported from northern Italy over a period of 3 weeks. 3 of these cases fit the criteria for axonal variant of GBS, while the rest of the 2 were suggestive of demyelinating neuropathy. Although each of these cases had a usual latency of 5 to 10 days before the onset of neurological symptoms, one of the patients, similar to our patient from China, was found negative on PCR at the outset, only to be detected positive subsequently. You remember what I said about the altered sensorium irony, that if the patient presents with only altered sensorium, you wouldn't think of COVID as the first thing. Same happens with the GB syndrome. There's a chance of the inadvertent exposure to the infectious virus in the neurology ward, both for attending healthcare staffs and other patients, because such patient will not be on an isolation or in a dedicated ward and would be a source of infection to the rest of the rest of the patients who do not have COVID. Secondly, GBS is a disorder known to rapidly affect the respiratory muscles, particularly if bulbar involvement sets in, which can cause sudden, poorly explained worsening of a patient's status if the diagnosis of COVID-19 has not already been established. Okay. The second post-infectious complication that I would like to discuss is acute myelitis. Another report from China described a case of acute myelitis, possibly affecting the cervical spinal cord, as evidenced by the clinical features in a known patient of SARS-CoV-2. In this particular description, also, the neurological symptoms were coincident with the febrile period of the illness, pointing more towards para-infectious demyelination rather than post-infectious complication. In this case, too, the markers of inflammation were raised, CRP and procalcitonin. Although the literature is scarce at this point, the idea that SARS-CoV-2 can cause para or post-infective complications affecting the neuroaxis at different levels seems realistic. And supposedly, patients with the inflammatory storm will be more likely to manifest this. Okay. Now, I would like to touch a couple, maybe just one disease, which requires our attention because of this subset of patient on immunosuppressive therapy. So we know that during this hour of pandemic, in general, the mobility of the population is reduced, and we hope so. But the patients with the neurological diseases are particularly at more risk of developing disease, and especially those patients who are on immunosuppression therapy. In neurology, to name a few diseases which require immunosuppression is multiple sclerosis and myasthenia gravis. I would like to discuss multiple sclerosis with you and other NMO spectrum disorders. So I would like to take a reference to this editorial published very recently on May 7, 2020 in Green Journal of Neurology. So now what the problem with this multiple sclerosis as a disease is that it obviously involves the respiratory system in the sense that it involves the bulbar pathways and can cause more pneumonia or more respiratory problems compared to the other population. So this is why MS patients are at the risk of developing COVID-19 or its complications or getting affected by this pandemic in a multifaceted fashion. So on one end, they are more susceptible to viral respiratory infections, pneumonias, or hypoxia. And on the other end, they are usually on continuous immunosuppression therapy. So they are really walking on a two-edged sword or on a very thin line. So what would we do in managing patients with COVID-19? So we are talking about an MS patient who has developed COVID-19. So if the patient has mild viral infection, we will continue the treatment just like that. And we wouldn't change anything. But if the patient has severe, complicated, hospitalized COVID, we will consider stopping the treatment and restart it after 4 weeks or when the symptoms have been fully resolved. Okay. Now, managing patients with MS but without COVID-19 infection. So there are two aspects to this question. One is of an acute relapse, and the second is of the long-term disease-modifying therapy. So in the acute relapse, this treatment is a dual-edged sword. Chronic use of corticosteroids. So what you all know that we usually treat acute relapse with high doses of corticosteroids. And corticosteroids are known to cause immunosuppression. So chronic use of corticosteroids is associated with an increased risk of infection. And short-term use of high-dose corticosteroids may increase the risk of herpes virus reactivation. So neurologists should consider having a higher threshold for offering steroid treatment during the COVID-19 pandemic. So I would repeat, a higher threshold. And acute, okay, one very important thing that you need to look very critically is that are the symptoms that you are seeing really a flare of MS? Is it really a relapse of MS? Or it could be just a transient worsening. Therefore, all the patients should be carefully screened for COVID-19 before receiving corticosteroids. Okay. Now talking about the disease-modifying therapies. So we have two main categories of disease-modifying therapies for multiple sclerosis. One are the drugs which do not have direct suppression of the systemic immune system. These include interferon beta and glutaramer acetate. And then we have drugs that cause systemic immunosuppression anywhere from mild to severe. So these therapies theoretically may predispose to a greater risk of COVID-19 infection and potentially more severe infection. So the decision of treatment has to be taken with utmost care and with consideration of the following factors. Number one, patient factors such as age and comorbidities that increase the risk of severe COVID-19 infections. Number two, disease factors, including disease activity before starting treatment and in the previous 12 months, disease course and disability. Number three, the drug factors. What drug are you going to choose and what are the potential problems with that drug, including the rebound disease activity if treatment is stopped, if you have to, if the patient goes on the ventilator. So this is a table. You may not need to look at it very closely, but I would, like to explain it to you. So on the top, you see those two drugs which have no risk of systemic immunosuppression. So if the patient is, if we are initiating the patient with one of these, go ahead. And the patient is already on it, you don't need to change anything. Then there are three drugs which fall in the low risk of systemic immunosuppression: teriflunomide, dimethyl fumarate, and natalizumab. In those cases, we can initiate the treatment as usual and continue the treatment, but we need to monitor the patient for a neutrophil count. For the moderate risk and for the high risk, you have to be very critical of deciding, and it should be with involvement of the patient, their family, the risk stratification, and possibly involvement of an MS expert. So I would like to conclude this here is by a saying by a great Chinese strategist who said that if you know the enemy and know yourself, you need not fear the result of 100 battles. If you know yourself, but not the enemy, for every victory gained, you will also suffer a defeat. And if you know neither the enemy nor yourself, you will succumb in every battle. Now, I would like all of you guys to reread these lines, but switch enemy with novel coronavirus. This is our standing right now as medical healthcare professionals. We need to know the enemy and we need to know our potential in order to deal with this pandemic. This brings to a very sad aspect of our medical success, I would say, in inverted commas. In the past century, we have made tremendous progress in the prevention, diagnosis, and treatment of disease. We can dissolve clots in the carotids, and hell, we are proud of that. We can fix mutated genes before they can cause harm and think we are so smart, we outsmarted a genetic disease. And we can image the brain and its networks with exquisite precision. Yet we have been brought down to our knees by the tiniest of organisms, about 60 nanometer in size. This is the time to step back, to retool and rethink. Where did we go wrong? We need to rethink how we need to train physicians in the practice of neurology and physician scientists in the academic neurology, and how we need to prioritize drug development for neurological diseases. And we need to enable academia and pharma to develop treatments not based on profits, but rather on cost to humanity. Just ask yourself, we can name like 20 viruses right now over the top of our head, which can cause encephalitis. But how many can we treat one of those? Just one. It is time for us to recognize that we are facing a crisis in neurology. The time to take action is now. Thank you very much. So questions, so Anna asked if I would like to ask that if you have a cough but no fever, does it mean you have COVID-19? Okay, so all right. So yes, cough can be a presenting feature of COVID-19. And if you have cough for a few days that is not going away, you can still have COVID-19. But this does not answer from an ID perspective or an ER perspective. And you need to get yourself checked in the ER for symptoms, and you would need expert opinion for that. Okay. What is your department experience here at SIH? How many patients develop neurosymptoms? What was those, or how did they present it? Okay. So at SIH, we are seeing, as a stroke neurologist, we are seeing less number of patients with mild TIAs, and mild stroke. So this one is for sure. We have also seen a couple of a large vessel thrombosis in young patients, but their COVID-19, their SARS-CoV-2 PCR came out to be negative. So right now we are working on the data we are working on the patients to have presentable data to find out what are our neuro complications of the COVID-19. But right now, I don't have any numbers to give you. Can old age, excellent presentation, thank you very much, Sabra. Can old age patients taking antidepressants are at more risk of developing stroke with COVID-19? No. So antidepressants do not mess up with your immune system unless you are depressed and you are not eating well, you are not taking care of yourself. So in that context, if you have a weak immune system for any other reason, you are more susceptible. Okay, so the question involves developing stroke with COVID-19. No, it doesn't. I mean, so far as we know, it doesn't. Headaches are such a common symptom experienced by all of us. What shall be one red flag sign to think of it be linked to COVID? Excellent question, Dr. Sidra. So yeah, like I said, if the headache is associated with fever, loss of consciousness, neck rigidity, you're a doctor yourself. So if you see in your patient's nuchal rigidity, altered mental status, confusion, seizures, so all of these are the red flag. So anything that points out toward the central nervous system involvement will be a red flag for headache. Dr. Adil, excellent information for healthcare provider. Thank you very much, Dr. Adil, makes me very happy. Okay, so I have been cued, and we have to wrap it up. It was excellent talking here. It was a new experience for sure. Usually my presentations are much more interactive, and I make sure that the audience is up and not sleeping at all. But this is the need of the hour. COVID is a new reality, and the nations even the individuals which quickly adapt to the changing realities of the world are the ones who survive. So yeah, this is the new reality, and it was great talking to you. And I hope to see you guys again.